Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z.
and John. Hi, Zara.
Hi, John. How's it going?
It's going really well. So I just want to really thank all our listeners and all our guest speakers that we've had this year. The support has been fantastic. We'll be 12 months old in March, so we've done really well. Talking about topics, we have a doctor from Australia with us tonight, Dr. Tom Forfa, who is on the Sunshine Coast in Queensland. So I just want to put a plug in from Queensland because that's my old state. So Thomas is a specialist in osteoporosis, and that's going to be our topic tonight. Overviewing osteoporosis for male and female, but there will be a concentration on males actually suffering from osteoporosis. And this is quite a devastating disease because it's underserved, listeners. So we're going to let Tom Forfa introduce himself. He had to get him off his surfboard and bring him into the studio. Let's go, Tom.
Thank you, John, and Zara. Thank you for having me. This is exciting. I'm really excited to be here. Yeah, so my name's Tom Forfa. I'm a retired medical doctor now, but I'm also an educator in the space of osteoporosis, basically because of my own journey of having it, naturally going about supporting my own bone health and getting myself out of osteoporosis. And these days I speak to other men and educate them on what's possible and how to do it, supplementing the medications and potentially replacing them if it's appropriate for them as well. Yeah, so I'm excited to be here talking about this for men and women as well. But we'll I guess we'll cover all the bases and dive into men's side because that's kind of what I resonate with the most.
So, Tom, would you like to just introduce to the people a little bit about the disease and what it entails? I mean, everybody knows or pretty well knows about osteoporosis in women, but it's good to review the data as well as the disease state and also maybe also talk about a little bit about prevention as well.
Yeah, so osteoporosis is an interesting condition in the sense that we never think about it until we've got it, because you don't see what's going on with your bones. And so osteoporosis is essentially the bone tissue deteriorating and breaking down to a point where it becomes fragile and we're more likely to break bone. And it can get so severe that we break a bone from sneezing, break a rib, or shaking someone's hand, that we break a hand. But generally, it's more things like falling from a standing height or falling out of a chair. And so things that you wouldn't normally associate with a broken bone, they end up in that. And worst case scenario is a broken hip. Generally, that is the worst one because it ends up in patients having deteriorating states of mobility, needing support, the exacerbation of other conditions, and there is a high mortality rate. Up to 1 in 5 people over 50 who do break a hip may pass away in the first 12 months because of the exacerbation of other conditions. But also there is the associated lack of mobility, and 10% of people 12 months down the track from a hip fracture will require long-term assistance. And with the growing population, the aging population that we have, this is going to become a more and more important topic in the next 5 to 10 years, if it's not already. And at the moment, there is a big growing base of people who are talking about this more, and I'm one of them. And yeah, the condition is a peculiar one in the sense that when we're told we have osteoporosis, all of a sudden it creates this sense of fear and uncertainty and lack of confidence, where we wonder, what am I going to break something? When am I going to break something? What can I do? What can't I do? And we tend to limit our activities, which then increases the risk of further fractures because our ability to balance and prevent fall deteriorates. We become deconditioned. And so it's very important to firstly, for people to understand the condition and for clinicians to look for it in their patients as well.
So, Tom, I think a couple of questions that I
first think of. And, I did a little bit of research prior to you, of course, coming on our podcast. And prior to even you taking us down your own personal story of osteoporosis and your exposure to it, can you explain to the listeners out there, because with osteoporosis, from what I've read, there is primary and then secondary, right? So maybe just explain the difference between primary and secondary. And then also if you could then tie in your personal story and how you ended up going down this path that led us to having this conversation with you.
That's a great question. So primary osteoporosis is the deterioration of the bone due to the aging process, or predominantly post-menopause where estrogen drops. And that kind of, for women, that leads to osteoporosis. And for men, it's kind of a similar story with the aging process, and testosterone levels might drop. So it's just a normal aging process. Whereas secondary osteoporosis is what it occurs when there is a very clear clinical cause for it. So it might be glucocorticoid medication intake over a long period of time, Cushing's syndrome, hypogonadism in men. There's a whole myriad of different conditions that could lead to it, but that's where a clinician, a physician, is important to help uncover that. And so women predominantly fall into the category of primary osteoporosis, whereas men more commonly have secondary. And this becomes really important in the prevention and diagnosis of osteoporosis, because it's not often thought about in terms of the secondary aspect. What are the particular risk factors in men? We tend to screen in women for osteoporosis. We're often very aware of that, but men not so much. And this kind of ties into my story, where I had no idea. I wasn't thinking about it. I was going on with my life, and around 2020, it was exactly in 2020, in between COVID lockdowns, I was going for a bike ride, and on a bicycle ride, and I was going quite slowly, and I hit a ditch, and I slowly came over the front, and I landed on my wrists, which for a 37-year-old, otherwise healthy male, you wouldn't think it would lead to a fracture, but it did. But on its own, you wouldn't think osteoporosis. But that was my third fracture in 18 months. Before that, I'd rolled my ankle and fractured it. I was doing boxing class, holding a thick pad in front of my chest. Someone punched me and broke a rib. And so I went to my GP and said, something's up here. And this is actually off the back of many fractures over the last 10 years before that, where my most significant one was 10 years before that, where I rolled the other ankle and broke it in 5 places. At the time, I was probably about 32, and I just left medicine, and I was going traveling, rolled an ankle, broke it in 5 places, which at that point I was given a referral to get a scan, and I thought, I don't need this. I'm a healthy man. I threw it away. But then, fast forwarded to COVID 2020, I've come off that bike. Third fracture in 18 months. My GP refers me for a DEXA scan, and that is the predominant way that we diagnose osteoporosis. It's like an X-ray where it scans your forearm, your hip, and your lower back, and then gives you a rating, which we'll go into in a second. But the results came back: osteoporosis in my lower back, osteopenia in my hip, and the difference between those two is, so going back to that, the DEXA scan, the X-ray. So when we do the X-ray or the DEXA scan, we're given a score called a T score, a T for Tom. And that score pretty much compares you to an otherwise healthy 25-year-old man or woman of your ethnicity. Now, whether that's an appropriate comparison is a topic of discussion, and we can get into later on, but that's kind of how they do it. And they compare you. So if your T-score is -1 or above, then you're about the same as a healthy 25-year-old of your gender and ethnicity. If it is between a -1 and a -2.5, you have pre-osteoporosis, we can call it that, which is osteopenia, which is a weakening of the bones, but not to the point where statistically we see fractures.
Okay.
And then when we go to negative 2.5 and lower, so -3, -4, -5, -6, then that's called osteoporosis. And that's where the scientists have worked out you're likely to fracture with minimal impact. And that's where your clinicians will get very concerned and start to talk about treatments. Now, just going back to my story there. So I was told osteoporosis in the lower back. And on top of that, where I had 2 crush fractures as well, which that's when I got really scared. That really kind of rattled my cage, so to speak. And I kind of started to doubt myself, all the health choices I'd made up until that point. I started to doubt whether was I going to keep breaking my back, so to speak, and was I going to become disabled? And I was only 37 at the time. And so a lot of questions and doubts and concerns kind of arose in my mind. And this is the experience that people have with osteoporosis. It's that the rug's been pulled out from under you. You can't see it. You don't know when you're going to break something. How bad is this going to get?
Is there a family history that should give a warning sign to people that are having 1 or 2 fractures early, that there's some family history that they should go out and get a DEXA scan? Because you threw yours away thinking, I'm really healthy. I know someone else that does those sort of things as well. And, you get some advice, you think, it's not me, I'll throw it in the bin. So is there something that the listeners should or should not do?
Well, if you're listening now, then yes, there are definitely things. For example, if you're over 50, if you're female, if your ethnicity is important as well, people from the Asia region and white ethnicities, if you've smoked throughout your life, if you've had other fractures as well, if you have a small body frame, if you have a low body weight, if you have a family history of it, if your mother particularly has had osteoporosis, there are a whole bunch of different risk factors that we can know of. There are also other ones that you're not going to be that aware of, hormonal imbalances, etc. You don't kind of realize that unless a physician talks to you. And that's, other than very informed individuals, it's more, in my opinion, the burden is on the clinicians to be aware of the risk factors, particularly for the gentlemen, if they've had prostate cancer and if they've had hormonal treatments for that. That is a big red flag. A lot of men end up with osteoporosis because it just bottoms out their testosterone levels, and that contributes to testosterone. So there are things that we can do if we know of. But yeah, it is generally the clinicians that really need to be aware of this and thinking about it 100% for women, and then also for men if the risk factors are there.
Was there a family history with you?
No, there was no family history.
Oh.
My mum even boasts about how strong her bones are and teases me about it a little bit. My dad has since had his checked. He's fine. There were no risk factors for me. In fact, when I spoke after being diagnosed, I saw an endocrinologist who's the physician of choice. There's also the rheumatologists who are important to speak to. And we did all the tests under the sun because I am male and I am younger than his usual patients. He was at a loss, and we tested just about everything. And there was no specific clear cause. But from my own kind of understanding of the condition now, because since I did a big deep dive and I've spoken to men and clinicians and I've put together a bit of a team, and I've since come to realize that for me, it was a combination of different factors.
Which were?
Yeah. Yeah, great question there, Zeke. So, and this happens to a lot of men so just before I go into that, what's my condition is referred to as idiopathic osteoporosis.
Okay.
Where my one of my medical school professors used to say that the idiots don't know the pathology, so it's called idiopathic. But we won't go down with that. So I kind of narrowed it down to a number of different. So firstly, I have gluten intolerance. So I'm not celiac, although that is one of the major causes. I've had the scope, so celiac disease is not. the cause for me. I have a gluten intolerance, which means that I inflame when I eat gluten and I don't absorb the nutrients. And so bowel and inflammatory bowel conditions can contribute to osteoporosis because of that very reason, but also the inflammatory component. There's a lot of research into that as well. But gluten intolerance was for me. There was also, I didn't consume much dairy. Throughout my 20s and 30s, I was against dairy ideologically for different reasons. And so I wasn't consuming enough calcium and I wasn't absorbing much. So that's a double whammy there. My testosterone levels are not below normal, but they're just on the edge of that, right? And so that probably contributed to it as well. Then I was also exerting myself. I was doing a medical degree, running a business, exercising, and that in itself, there are a number of studies that show that the body's and muscles' adaptation to exertion and long periods of exercise and activity does draw on the components of the bone to help the muscles function. So kind of adding all of that together, it's a great cocktail of reasons for why I ended up, with the weakest bones in the family.
So, so just to kind of summarize what you've said for the listeners out there, it could be, for you, it was underlying contributory causes, medical condition, i.e. you were gluten intolerant, but you were also under external stressors, starting up your own business, medical school or medical degree, sorry. And then, but you're not a smoker. Otherwise, you were a healthy eater. You did not consume dairy.
Yeah, that I was always very health conscious. I exercised, and I've always been thin as well, and lower body weight, and that potentially could contribute as well. So I've kind of categorized it into three main areas of causes that I like to think about. And I encourage people to do so. The first is conditions that prevent all the different nutrients getting to the bone. So inflammatory bowel conditions, celiac, Crohn's disease, ulcerative colitis, for example. And then there are other surgical contributions where if people have had resections of bowel or stomach, that can contribute to that. And so problems getting the nutrients into the system. Secondly, conditions that prevent the creation or proper creation of stronger of bone, and that might be liver issues, kidney problems. Then we've got the third category, things that are drawing nutrients and calcium out of the bone. And this is probably the largest in my opinion, and there's a whole different array of them where essentially the bones are not just there to keep us upright. They're not just there for structural stability. I like to think of them as a storage bench. So just a quick story here on the Sunshine Coast in Australia, there's not much to do. We live in a beachside town, and if the school holidays are not on, it's very quiet. The only thing to do is to go to the beach and go to a cafe. And so we spend a lot of time in the cafes. And one of my favorite cafes, we were there with my wife, and the barista walks up and reaches under my wife. She's sitting on the bench. She reaches under the bench and grabs a carton of milk. And it kind of got me thinking about the bones, because they're very much like that. They are support where we sit on them, where they help to keep us upright, protect the internal organs, but also they're a storage facility for things like calcium and magnesium and zinc in men, which our body can't produce otherwise. So we need to absorb it, store it in the bones. And if we're not absorbing it and eating it, then the body's going to draw it out of the bones no matter what. We need calcium for the heart to function. And if it's not there, we've got far more serious problems than broken bones.
Is there any one of the three that's worse than the other?
Oh, it's hard to say that there, John, because everyone's a bit different. Everyone has their own the reasons. I think if we were to generalize for the female population, because of what happens after menopause, is there is a drop in estrogen. Estrogen is what's called osteoprotective. It protects the bones. It makes sure that they are being so bone is not like a brick. It doesn't just sit there for the rest of your life. it's more like a garden where it's called, the body's constantly clipping the leaves and new leaves are growing. So the bone is being resorbed and new bone is being laid down throughout our whole lives. And after menopause, when estrogen drops, that balance of creation versus resorption swings towards the resorption. So more bone is being taken away. So that would be the most kind of the largest cause for women. For men, it is hard to say because there are the secondary causes, and it is important for men to have a chat with a physician to dig deeper and to remove any potential causes for them.
And
So,
okay. So John and I always do this. So the question I had was, you mentioned, like, in terms of, I'm just going to say screening or diagnosis, right? You mentioned the DEXA scan. Okay. Are there other tests that can also be done in order to better determine, or the laboratory tests in addition to the DEXA scan or any other scan?
This is where things get exciting. This is where things get so for many, many years we've been using the DEXA scan, and there are some limitations. It's the gold standard, it's easily accessible, very available, cheap to run, but it has its limitations in the sense that all it looks at is how much bone tissue there is. It doesn't actually give you an indication of strength or likelihood of fracture. So if we were to think about bones, like you have a stick of chalk versus a pencil, the stick of chalk is very dense. There's lots of stuff in there. Then the pencil is not as dense. But if we were to drop both of those from the same height, which one's more likely to break? The
Sure.
chalk, right? But it's far more dense than the pencil. Well, why is that? Well, the pencil, the microarchitecture, the little fibers and how they're structured are far more effective at preventing fractures. And and so the DEXA scan only looks at how chalky our bones, essentially how dense they are. It doesn't tell us the microarchitecture. There is some little technology with the TBS, but the DEXA scan just looks at that. Whereas there is a new technology that's been approved by the TGA in Australia, the FDA in the US, called the EchoLight REMS. And this is an ultrasound technology where it looks at essentially, just to give everyone a simplified explanation, it shoots ultrasound signals and collects them and looks at the structure of the bone, but as well as the density. And the reason why that's important is because two people can have the same bone density, but one could have a poorer microarchitecture than someone else and be at higher risk of a fracture. So the microarchitecture this research is showing, is becoming far more important, and it's the cutting edge now of osteoporosis diagnosis, but then also looking at fracture risk. And the REMS gives you the T-score, but also a fragility score, which shows you your likelihood of fracturing something, which becomes very exciting for and reassuring as well.
So how easy is it to for people to access the REMS?
That's one of the limitations at the moment. It's not widely available. It's very mobile. So it's not like a big X-ray machine where it's stuck in one center, but oftentimes these days the sonographers who administer the REMS, they move around. But so you'd have to look it up online. That there aren't that many of them around, but if you can get them, they're great. That's the diagnosis. The diagnosis is made on the DEXA scan, and then also the REMS as a supplementary option there. Then the blood tests, also a very interesting aspect to this. Now, the blood tests can't be used for just the diagnosis. However, they can be used effectively for managing and tracking progress of treatment. So the blood tests, essentially, when bone is being broken down in the body, the body releases these signals into the blood. And also when the bone is being created in the body, the bone releases these signals. Now, that's constantly happening no matter how old we are. The bones are constantly being broken down and new bone is being laid down. So these signals are always being released, and we can do blood tests to test the levels and also how they compare to each other, the breakdown ones versus the building ones.
Are there specific markers? Like, are there specific blood tests or markers that people should be aware of? Or
Yeah, the kind of gold standard ones are CTX for the breakdown of bone and P1NP for the building of bone. There are a whole range of them, but the research and the different organizations have kind of distilled it down to those two. Interpreting them can be a bit of an art as well as a science. At this point, it is requires a bit of interpretation. So it is important for people to work with a clinician on this one. But
Is it
often
is it standard, Tom? Would the interpretation in Australia be similar to the interpretation in the United States versus Europe, or is there a difference interpretation?
It does vary. The units vary, the ranges vary. And so this is why it's important to work with a clinician on this one. And then it also depends on what's the context in which we're testing them. If someone has recently fractured a bone, the body's naturally going to have higher levels of these markers because the body is just actively turning over and building new bone. And if we're taking medications, then that's also going to affect these blood markers. And that's predominantly how they're used is to track the treatment of osteoporosis with the various medications. Now, in terms of the other thing is, it depends on which clinician you speak to as well.
Yeah.
Unfortunately, when I speak to a lot of my doctors here in Australia, their information is from 2014, but there are far newer studies and there's far newer information, and there are people who are more advanced in understanding this and interpreting it. But that will depend on the clinician you speak to and their experience with it.
I was going to say, how does this relate to our topic today about men? And you said it's primary and secondary. Men are more secondary.
Yes.
Therefore, the onset is more dire, more rapid, and the risk probably may be greater because men don't do bone. That's my knowledge, right?
Generally speaking,
Like you.
tend to have worse outcomes when they fracture with osteoporosis. They are underdiagnosed and tend to be undertreated because we don't think about it in men. It's seen as a condition for women. And so when men get it, well, it's just a broken bone. Let's treat it. Let's treat the bone itself and move on. But then when someone has an osteoporotic fracture, they're at an 86% or 87% increased risk of having another one. And so then these men continue to fracture and they don't get back to their pre-fracture level of functioning. And so they can deteriorate and become very unfortunate at that point. But yes, to your point, John, about the causes. So secondary causes. So this is the really important thing where, depending on which country you're in or which clinician you speak to, they'll have a different approach. When you do that, if you've broken a bone, if you're lucky enough to get a DEXA scan, they'll either write you a prescription and say, take this, with not much explanation. And this is based on what I've heard from many people talking to me. Or your clinician may sit down with you and have a chat about osteoporosis and what it is. And ideally, they will then do investigations, whether you're a man or a woman. They will do investigations to look for causes and underlying potential kind of contributing factors to it. Because that, in my opinion, is key, especially for men, to be able to start taking control of their bone health and reversing and improving that situation. Where for myself, once we had, essentially I had the green light to an extent. I had removed gluten from my diet. I tried to address all the things preventing me from building my bones. And then it's a matter of getting to work and triggering bone growth.
Right. And I think you mentioned something very critical here is reversible, right? So you just said that this is potentially reversible. So how would you now advise others that have gone down that path? They've been diagnosed, they've had the DEXA scan, they've had that conversation with a clinician. So what is your strategy for, kind of reversing this?
Yeah, and so there are studies showing that you can strengthen your bones and you can improve the microarchitecture. There is a lot of exciting stuff happening at the moment, and not just in the medications. The medications, depending on the individual, and it's important to speak to your clinician about those, but there are non-medical ways or non-pharmaceutical ways to strengthen your bones, prevent falls, improve your balance. And the way that I did it was I started working with an exercise physiologist, who's kind of like a physiotherapist. And we essentially, the bones don't naturally grow after the age of about 25, 30, unless we force them to grow. We have to trigger them to grow. So they've got all these little cells throughout them called osteocytes, and their one job is to sense for little twists and turns and movements that then trigger bone growth. Like, this is physiologically programmed into our bones. And so the key is there to trigger that growth. And so the way we do that is through the right types of exercise. Now, I know what you guys are probably going to ask, what is that exercise? And I want to get into that. But what's really important for people to know is that we don't just go from having broken a bone to intensive exercise. Like, there is a progression that we need to go through. And this is something that I experienced myself when I saw my exercise physiologist. I had previously broken both ankles. I was deconditioned, and so I hadn't rehabilitated my ankle, so I couldn't hop on or barely stand on one foot. And we started with just the basics. And the basics are to rehabilitate your kind of fractures or limitations. People I speak to might have shoulder problems, lower back issues, knees, and we need to start working on those. Then slowly over time, we start to increase weight-bearing exercise. And this is where it gets exciting, because there's a concept called Wolff's Law. Wolff was I can't remember his first name, but he was a German physician from the late 1800s. Now, this is how long we've known this, the late 1800. And he found that if we put pressure on the bones will strengthen based on the pressure that we put on. And so, and more research has been done on this since then. The Lift More trials were fantastic studies out of here in Australia that looked at women and then men, putting them through high intensive resistance and impact training, which essentially is lifting heavy things and jumping. So just to simplify it significantly, there is a bit more to it, but just to kind of simplify it, the idea is to put that pressure on the bones and on the muscles, and then also to, when we jump or hop or do heel drops. So these are all things that people can do. And the studies were done on people with very low T-scores, mind you, for men and women without fractures in highly supervised conditions. And they were very effective. They're very cautious in how they word it, but essentially their bones got better. Now, just going back to the exercise, so we need to progressively improve. So build the foundations to address any limitations, start to increase the weight-bearing exercise, then add impact exercise, because when we send that signal to the bone, it knows to start growing. And that's kind of the key, that weight-bearing impact exercise. And I know that a lot of people are not very excited by the idea of going to the gym and lifting heavy things. As much as that is the fastest and most effective way to do it, we can do things like skipping rope or hopping or dancing. There are different activities that can essentially simulate that experience.
Would listeners out there that are interested to pursue this, would they have, like you said, you need to have a clinician that is aware, but you worked with a exercise physiologist. So is that someone that one would need to seek out, or are there like physiotherapists?
Physiotherapists as well. Someone who knows about osteoporosis. There are guidelines on this from different organizations. And so it'd be important to have someone who, and the thing that I really want to emphasize is that progressive process where we don't just go from 0 to 100 jumping up and down, because we need to rehabilitate these different ailments. Like for myself, even at 37 at the time, I needed to start with just bending over with a broomstick along my back just to make sure my posture was well and my core was strong. I mean, I've slowly improved that, and to the point where just this weekend, I competed in my first powerlifting contest, trying to lift the heaviest thing I could possibly lift up off the floor. And I can happily say there were no fractures involved in the making of that contest. And so
Congrats.
there are definitely people
Congratulations.
to speak to, exercise physiologists, physiotherapists, personal trainers. I'm a bit hesitant about, because it just depends on, it is very important. The particular exercises are very specific, and that process of almost rehabilitating the body to a point where you can sustain this type of exercise is important.
In your pre-discussion with us, if all that fails, is there pharmaceutical agents that are now on the market to assist and develop with bone function? I think more people know it for women, but maybe we could go through those and some of the pitfalls.
Yes, there's a whole lot of pharmaceutical agents, and that might not be the last case. It might be the first case. It just depends on the individual. And the pharmaceutical agents kind of fall into two broad categories. The first ones are those that prevent the further breakdown of bone. They're called the bisphosphonates. That's the major ones. Denosumab is another one. And so these essentially, you can take them as a tablet. Sometimes they're daily, weekly, monthly. Sometimes they're injections, but they essentially prevent the further breakdown of bone. And that's what's referred to as the first line treatment, where you see a physician, they'll give you that first. And if that isn't working, or if you're not responding to it well, whether you're having side effects like adverse reactions like gastrointestinal issues, ironically bone pain, muscle aches, that you can get more serious and scary with osteonecrosis of the jaw, which is a rare potential side effect there. Now, if you're not responding well to the first line, they'll give you what's referred to as the second line treatments. And these are the anabolics, in the sense that they aim to build bone. And so these are usually injections. And these are very exciting, and people like to do those, although they're expensive. And you can only take them for 2 years. And this is the frustration that many of the people I speak to have, and that I had myself, that you can only take them for 2 years. What happens after that?
Right.
And the answer generally is more medications. So those bisphosphonates, those preventing of the loss but medications. And then you're on this lifelong weird rat's wheel of medications with potential side effects, and they're very effective. And speak to your doctors, make sure it's right for you, etc. But the people that I speak to, they don't want to be on that journey, and they're concerned about the potential side effects, and they want to see if there are other ways to do it.
Right.
And even if you are taking the medications, which might be the right move for many people, the exercise and the nutrition and the supplementation is very important to help prevent falls, to improve your balance, to help you feel better, generally speaking, and to potentially maybe one day see what you can do with the medications down the track if it's safe and right for you.
Now,
So,
John, you and I are going to ask the same question. I know we are. Am I going to say it's prunes, right? Right, John?
Yeah.
No.
Yes, I couldn't believe it. We were discussing when we first met Tom. I had a long discussion that he mentioned the role of the prune, which was
the prune is
which was
the
it was eye-opening for me.
He's the unsung hero of osteoporosis and healthy bones. And studies have been done on this. I'm not making this up.
Well, I know.
They have done them on women and men to a certain extent as well. They have shown that 50 grams of prunes per day, and which is about 6 prunes, depending on how big your prunes are. 50 grams of prunes per day, or at least 12 months, have been shown on their own, without any other contributing factors, have been shown to prevent the bone mineral density loss in the hips in women. Just prunes, right?
Wow.
And in men, they've tested the blood turnover markers, and they've shown that there is a positive change in the bone turnover markers for men. Now, what's really interesting is if you can stomach the prunes, doubling. They compared no prunes, 50 prunes, 50 grams of prunes to 100 grams of prunes per day. And they found better results with the 100 grams of prunes per day. However, the problem was sticking to the regime because, as we all know, prunes have a very potent effect on our gastrointestinal system, which, can be positive for many people as well. And, being able to stomach that for a long period of time, people weren't able to stick to it. So they've kind of pulled it back to 50 grams. And the way that they did the study was they started with 2 prunes a day for 2 weeks, then add another 2 prunes a day. So you're on 4 prunes a day for, obviously this isn't medical advice, but this is how the study was, for another 2 weeks. And then they went to 6 prunes a day, and, people were able to stick to that. And the results were surprisingly positive. Now, the question is, how does that happen?
Yeah, I was going to ask that. Yes.
Yeah, how does that happen? And some people think it's boron. It's not got nothing to do with boron. It works on the gut and the anti-inflammatory effects of prunes. That's why it's prunes, not dates, and that's why it's prunes rather than the plums that they come from. They have an anti-inflammatory effect, and they're on the body and the bones, and so
getting the absorption of all the other minerals that you need then, because the inflammation is taken care of?
Well, inflammation is actually a big contributing factor to osteoporosis. Now we're really getting in the weeds, John. Like this is there are so many different things to osteoporosis. And I'll tell you what. So inflammation is a big one. Now, inflammation is the problem that I have with this so vague, esoteric term of, everything, anything. It seems like anything and everything can cause inflammation. However, there is clear evidence showing that the inflammatory factors, what they do is they upregulate or turn on the activity of the cells that break down bone. And so inflammation can come from all sorts of different osteoarthritis, all different kind of conditions can lead to that. So it is, I'm not a fan of kind of esoteric, scary kind of things. I like to be very practical, probably for myself, because I like to break it down so I can do something about it. But yes, inflammation, if we can reduce that, then that is definitely a bone protective, has bone protective outcomes.
So within my research that I was doing prior to this podcast, you had mentioned about, you discussed about prunes and specifically around the polyphenols. So polyphenols were contributing, or the benefit of that was, to your point, it's antioxidants, so anti-inflammatory. And then you also have the promotion of osteoblasts. So you're actually building bones, so promoting bone metabolism. But then there's also an effect on the gut microbiome. So could you speak to that a little bit, maybe?
That's not within my expertise at this point. Z, I mean, I think from my kind of point of view and the people I speak to, I just know that the prunes have a great effect, and it is anti-inflammatory. It reduces the inflammatory effects, but the details I haven't gone into exactly how that works, and but I'm happy to go further into that at a later date.
Okay, that'd be great. And if you could share that paper that you'd mentioned, that'd be great.
Yeah, the prunes one, yes.
Yeah, because then we can attach it to the for the links for people if they want to read it.
So Tom, there'd be a lot of people listening to this. How do they get in contact with you if they've got questions following this particular episode that we're doing regarding osteoporosis? I know that you've got YouTube videos, you're on the internet regarding your humanitarian activity, and I just want to compliment you and your team on that. You do an amazing job for the children. How would they actually follow you and get the information other than the YouTube videos that are available to them on this particular topic?
So they can go to our website, bonedensityeducation.com. We have some resources on there. They can also follow us on social media. If you type in Bone Density Education, that's our handle. But yes, YouTube, website, social media. And thank you for the kind words there, John. Yes, we're trying to do a lot of good, whether it's in bone health, whether it's for children, whether it's for doctors. And my mission with all of this is to make osteoporosis a truly reversible, drug-free condition. Where and the way I want to do that is help 1,000 men take control of their bone health, reclaim their confidence, and get back to doing the activities that they love to do. So hopefully, we can help people do that in the coming couple of years.
And so those 1,000 men, is that global, or is it situated in Australia or Queensland, or is it a global trial that you're going to be initiating?
It's more of our mission to bring them with us. And so it is global. We have about 50% of our men are in Australia. The other 50% are overseas. We've had men from Ireland, Canada, the United States, and wherever there's an internet connection and a man who needs his bones strengthened, we can be there.
Which is absolutely fantastic. And so we're well over our time that we said we would be. Obviously, we would love to have you back to discuss more about osteoporosis.
I'm happy to come back anytime you need me. If there's any more clarification, we can talk about the gut microbiome and go into the weeds on that one as well.
Okay. I think that would be really, really good. It would made into this episode. Tom, I just want to thank you from everybody here and our listeners for this great introduction into osteoporosis, specifically the men as well. And the insights that you've given today have been unbelievable. So thank you for all the research that you're doing. Thank you for your humanitarian research and work that you're doing, especially with the children. And also the work that you're doing, getting doctors to go through the GEMSAT. So thank you there. That's an amazing story within itself.
Thank you. Thank you, John. Thank you, Sue.
Tom,
There's so much to say.
It's been very enlightening. And before we hang up, before we let you go, because John and I always ask this of our guests, we ask that you kind of give us your top 3 key takeaways so that listeners can have something to go off by. So what would be your top 3 key takeaways from this conversation?
Okay, so the first one would be, if you've been diagnosed with osteoporosis, is to learn more about it. Just research as much as you can about it so that you can make a more informed decision. Second would be to engage in the exercise and the food aspect of bone health. It will, even whether you take medications or not, it will make a huge impact. And then the third one is to be kind to yourself and have patience with it, because it is a long-term, for the rest of our lives, really. Like, I will never be able to stop doing these activities, which I really enjoy now anyway. So the key is to find ones that you enjoy and be patient with yourself.
And that's great advice. And prunes, don't forget the prunes.
Thank you. Hey, if you do nothing else, the prunes.
Thanks, Tom.
Thank
you. Happy holidays to you.
Yes,
yeah, happy holidays.
Happy
Thanks,
holidays.
John.
Bye. Bye. Ciao. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.